And welcome to this video about the Mental Health Act, and specifically the one in Canberra in Australia. My name's Sil. I'm a junior doctor. I'm in training to become a psychiatrist, and unfortunately I have to use the Mental Health Act quite often. So it's really important that I have a good understanding of it. I'm making this video not only to help me kind of solidify my learning about the Act, because I've had to study it a lot in the past couple of weeks, but also to help people who maybe unfortunately have been placed under the Act. So I hope to keep it kind of simple, not just for medical professionals, to help students who are learning about the Act, or for people like me who have come from a different state and gone to Canberra with a new kind of with a new Mental Health Act. This would also be really useful if someone you know is placed under the Mental Health Act. It can teach you a little bit about the legality and the processes that are happening behind the scenes, because it can feel a little bit unfair at times, but this is to show you that there are incredibly thorough processes that happen to protect the rights of people who might be considered to be placed under the Act. In this talk, we're going to start broad, and we're going to talk about the kind of why there even is law in the first place. And then we'll talk specifically about the actual Mental Health Act 2015 of the ACT. We'll talk about mental illness, mental disorders, what they're not. Okay, when is someone mentally ill? When are they not? Then we'll talk about the process that one goes through when they're being treated involuntarily. So emergency apprehension, an ED3, emergency detention for 3 days, and an ED11, emergency detention for 11 days, and then a PTO, a psychiatric treatment order. So I guess a fair place to start is, why is there a Mental Health Act? Well, 14 billion years ago, there were no humans. There was just the start of everything, matter and a plasma of protons and neutrons and electrons, and then that the Big Bang happened and expanded, and chemistry began, and then eventually 4 billion years ago the Earth was around and biology began, and then 200,000 years ago, as biology was continuing, humans were formed, and then humans were really the first animal ever to be able to have what are called intersubjective beliefs, which are essentially a shared belief across an entire species about a thing that you cannot see. And that is, the reason we have become such successful animals and been able to coordinate in such large numbers. Unlike any other animal, we can share beliefs of things we can't see. And why am I talking about all this kind of meta-philosophical jargon crap? Essentially, it's because law is one of those beliefs. So, human rights aren't a physical thing. Human rights aren't something that can suffer. Human rights are a made-up story that we all agree to, which I think is a good thing, because essentially human rights are aimed to reduce unnecessary suffering. The legal system and laws are all essentially designed to preserve human rights. Okay, it's more complicated when you look at particular laws, and so let's do that. Let's look at the particular Mental Health Act. And the Mental Health Act is a law that tries to protect the freedom and rights of people who are suffering from mental illness, as well as the society in which they live in. And so, in a nutshell, if someone is a risk to themselves or others to a point that is unacceptable, then psychiatrists are given the power to treat people against their will. That is it's in the interest of the individual and of society that a law like that exists, but the problem is this has been abused in the past, and it's really important to know what mental illness is, when you can treat something against someone's will, and keep someone in a hospital against their will, and what mental illness isn't, when you can't do such a thing, because there's an incredible infringement on their personal rights that if someone doesn't want something and you're doing it against their will, you have to have such good reasoning that is the right thing to do for society and for the person later on. And I've seen enough patients kind of tell me that they are so grateful that they were treated against their will when they were unwell. So people, for example, who have bipolar, who are manic, who had broken up with their partner, quit their jobs, and wanting to spend tens of thousands of dollars on buying 4 kind of nice supercars or whatever, maybe not tens of thousands, hundreds of thousands of dollars, and they don't want to get better because they're manic, they're loving it, and they're having a good time. But you treat them against their will because you can obviously see all these risks, and when they get better, they say, I now realize how unwell I was. Thank you. You've changed my life. They're a different person. And so that's why this exists, because it's freaking important, and it wouldn't exist unless it was really important. So let's talk about mental illness. Now, I'm just going to quote it straight out of the Act because I think that's probably the safest way to go about it. So, mental illness means a condition that seriously impairs, either temporarily or permanently, the mental functioning of a person in one or more areas of thought, mood, volition, perception, orientation, or memory, and is characterized by A. The presence of at least one of the following symptoms, which could be delusions, hallucinations, serious disorders of streams of thought, serious disorders of thought form, or serious disturbances of mood, or B. Sustained or repeated irrational behavior that may be taken to indicate the presence of at least one of the symptoms mentioned in paragraph A. Now, a quick run through these symptoms for those who aren't medical or don't work in mental health. Delusions, these are fixed, false, rigid beliefs, unshakable. Very common ones are paranoid delusions, like like you're being followed by bikies, being hacked on in your computer, being monitored through TVs or through your computer, or whatever. But there's lots of other types of delusions. People can be grandiose. People can have sexual delusions, like some people think that they are married to Elvis Presley, or things that don't make any sense. And some of them will be called bizarre because they're completely impossible. Hallucinations is a bit different. This is actually a perception. You're experiencing something from a stimulus that doesn't exist. So you're hearing voices, but there's no one talking, or you're feeling things crawl on your skin, but there's nothing there crawling on your skin. Or you might see things, but there's not actually the things there to see. So it's internally generated perception. Now, serious disorders of streams of thought and serious disorders of thought form, as far as I know, are the same thing, and I don't understand the difference between streams of thought versus thought form. But this is essentially, if someone is, for example, very manic, you can't follow their stream of thought. And the only way you can assess someone's stream of thought is through how they're speaking. So hopefully you're listening to me and I'm a linear thought form. I'm making sense in a logical, linear way. But if someone is very unwell and manic, they might be talking about one thing, then another. The other day I was talking to someone, they started talking to me about the dark side of the mood and how APRA is monitoring me, and then he made $1 million, and that's why you shouldn't bite shark teeth because they're going to hurt you, and that's why the Opera House is going to get me. I couldn't keep up, and you feel that when you talk to someone like that. So that's a disorder in thought form. In that case, you'd call that loosening of associations. One thing is not following from the next. So that's mental illness. Mental disorder. A mental disorder means a disturbance or defect to a substantially disabling degree of a perceptual interpretation, comprehension, reasoning, learning, judgment, memory, motivation, or emotion, but does not include a condition that is a mental illness. So previously, for example, if someone had a personality disorder, now that's considered a mental illness, but previously it wasn't. So it was considered a mental disorder. But if someone is very upset and emotionally labile and threatening suicide or threatening to hurt someone else, that would be mentally disordered. But also intoxication, if you're not logical and you might be mentally disordered. So those are the two common areas as far as I've seen it in mental disorder. Now, in the Act, it specifies what isn't a mental illness or disorder, and this is really important because previously in history, psychiatrists and politicians have worked together to kind of call people insane if they don't agree with a certain ideology or religion or whatever. So it literally says, let me just read it out. For this Act, a person is not to be regarded as having a mental disorder or mental illness only because they have any of the following. So a particular political opinion, a particular religious opinion, a particular philosophical opinion, a sexual preference, which, don't forget, psychiatrists used to consider homosexuality to be a mental illness, sexual promiscuity, immoral conduct, illegal conduct, alcohol use or any other drug use, or antisocial behavior by themselves aren't mental illnesses or disorders. Doesn't mean that there's not a mental illness and disorder if they have one of these things, but if it's just by themselves, it also doesn't mean they have a mental illness. So that's just an important caveat to the whole Act. Now we've talked about what is and what isn't mental illness, we should also talk about the process of someone becoming an involuntary patient, or that process being revoked, because it can be revoked. So the first thing that usually happens is, it's either the cops or the ambulance usually. It can be a doctor, but it's usually cops or ambulance who realize there's something wrong. And so they have the power to do what's called an EA, or an emergency apprehension. That's the first step. A statement of action that basically says, I'm worried about a risk to self or to others, probably secondary to a mental illness. I don't have to know that it's a mental illness. You're just an ambulance or a police officer doing your job, but you're worried that because they're mentally disordered and because of that, there's a risk of harm to self or others. And so you are you are placed under an emergency apprehension, which forces you to go to a hospital for a review. Okay, you have to go to hospital for a review. If you refuse, the police can use force to enact that apprehension. Now this is a pretty crappy situation for people who are being placed under emergency apprehension, but they try to protect these people and by getting them a swift review. So it is a law that you have to be reviewed within 4 hours of getting to an emergency department for review. In exception, it can be 6 hours. So it can be pushed to 6 hours, but at the 4 hour mark, alarm bells go off and it has to be seen within 6 hours. And so if someone gets to the 4 hour mark and hasn't been reviewed, that's very stressful for us psychiatry registrars, because, after 6 hours from arriving, they essentially have the right to leave. So you will be seen within 6 hours and hopefully within 4 hours. What do I mean by be seen? Well, it's essentially what's called the initial examination, and it can be any doctor that does it, and they just have to start the process of seeing you. But there's a couple of requirements as part of that examination. So the first is it has to be in person. The doctor then considers the observation arising from the examination and considers other reliable and relevant information. So that part C, that means that the doctor, if needed, can contact other people, the police, family members, partners, ex-partners, unfortunately, even if the person doesn't consent. At this point, the most important thing is getting the truth, even if that means breaching consent. That doesn't mean they can breach confidentiality, right? That doesn't mean that. So if there's someone that I'm seeing and they don't want to talk to me, they're not going to tell me anything because they're guarded, they're suspicious, they don't trust me. Which is their right, but that means I have the right to then talk to the police, talk to their family, talk to their loved ones, even if they say you're not allowed to talk to anyone. Still, you're not allowed. I've got to say, look, I'm sorry, I need to get the truth, and this Mental Health Act protects me to do that. Unless you want to talk to me and give me some information, we could work together. So what is the goal of this initial examination? Well, the goal is to consider an ED3, which is placing someone under emergency detention for 3 days. And the key kind of criteria that need to be met for an ED3 are that the doctor believes that the person requires immediate treatment, care, or support, and the person has refused to receive that treatment, care, and support, and the detention is necessary for the person's health or safety, social or financial well-being, or for the protection of someone else in the public, or for the public. And adequate treatment, care, or support cannot be provided in a less restrictive environment. This is a very important point to kind of focus on. We always provide care in the most effective, least restrictive environment. So if someone comes in under an emergency apprehension because they were arrested by police, because they were acting bizarrely at a train station, and they come in and they say, I'm happy to be treated voluntarily, I know something's wrong, I'm voluntary here, then you don't get the ED3. You're voluntary. That's great. We'll work together to get your mental health better. But if they are refusing and they need urgent treatment, as per the points I just went through, you need the ED3. Now, to further protect people and to make sure that we're as right as can be, it's not just one doctor's opinion that can restrict someone's rights to keep them under an ED3. You need 2 doctors' opinions. And if they're both not full-fledged psychiatrists, one of those 2 doctors also has to call a psychiatrist to get phone advice. But if one of them is a psychiatrist, then that's enough to place someone under an ED3. But here's the thing. Then within 24 hours, they get a second review to uphold or not uphold the ED3, and that has to be by a psychiatrist. So that's a very thorough assessment, right? That's 3 doctors initially maximum, plus, so it's two junior doctors and a psychiatrist, or 1 junior doctor, 1 psychiatrist in person, plus another review by a psychiatrist the day after. And if it's upheld and you want to continue it, then the next step in the pathway is what's called an ED11. All this information, by the way, can be found under Section 85 on the Mental Health Act, and it's freely available on Google if you want to find it. So if the team feels, within 1 or 2 days that this is going to be a longer admission, that the crisis isn't stabilizing and that this person needs longer involuntary care, the team can apply for an ED11, and that's to the ACAT. Now, during the ED11 or the ED3, the law states we have to do the least restrictive, most effective form of care. But just to clarify, because it's a common question, that does mean that if a person is refusing oral medicines, that we can give them intramuscular injections, which might be particularly important if someone's having, is aggressive or behaviorally, agitated and attacking other people, and they need to be kind of, because code blacks are very common, which is when security need to kind of hold someone down. And so that we minimize physical restraints, which can cause harm and and staff can get hurt, it's important that we have some chemical sedating medicines to help people just chill out, have a nap, and in a couple of hours feel a bit better. So at the end of the ED11, the team during that time will have decided whether someone needs ongoing involuntary treatment, or they've resolved and they can kind of be discharged as a voluntary patient, and they can revoke the ED11 at any time or let it lapse, let it expire. It's quite common for it to become a PTO, which is a psychiatric treatment order in Canberra, and that means involuntary treatment for 6 months. It might be shorter. Sometimes the tribunal only grants 3 months, but usually we apply for 6 months, and that's in a kind of chronic mental illness, that someone who has a psychosis or bipolar, who needs longer term treatment. And it's important to help people have as much autonomy as they possibly can, help them, try empower them to make decisions about their care where reasonable. But the PTO does allow for the treating psychiatrists to decide in which facility does someone get treated, like as in community or as an inpatient. And I guess the PTO also allows for people to control whether there's a community mental health team involved, their visits, making sure that people take their medications. Usually there's a depot, so a monthly intramuscular injection for people who don't want to take pills. And the process of applying for a PTO involves going to a tribunal. Now, what is a tribunal? Well, as an inpatient, you will go to the tribunal, and it's a room full of people. And it's kind of like a courtroom, unfortunately. There's a judge, essentially, called a presidential member. There's a tribunal psychiatrist, which is a doctor who considers the patient's care from a more objective point of view than the team, like a kind of second opinion kind of thing. And then there's the legal aid or the legal defense for the patient, and a public advocate to make sure that psychiatrists aren't, doing anything inappropriate from a public values, human rights point of view. And then there's usually some nursing staff and other clinicians and a liaison member. So quite a lot of people in the room. It's a pretty sad kind of. It's a bit unfortunate that we have to do it that way, because the way that it kind of is done is like we're in a competition with one another, like where it's kind of antagonistic, where the treating team is saying this person needs treatment. The person themselves are trying to defend against this accusation, this assessment, by saying they don't need treatment. I guess the key thing is it's kind of like a prosecutor and a defense in the courtroom. It's kind of like watching Suits, but it's such a shame, because the goal in medicine is not to be combating each other. It's to be a team. We want to be on the same page, but often people don't have insight into their mental illness, which means we have to do things against their will, because will is based on insight. And so you get these, awkward, not therapeutic kind of discussions to the panel being like, we think they have these delusions and this hallucination, and they're saying they don't, and that the team is not, respecting them and things, and it's a really challenging dynamic. But there's no better way to do it. I mean, if you have a better idea on how to do this, please share it in the comments below, because it's really, really tricky. So that's kind of where so essentially the treating team will provide the patient and the tribunal with a report. They'll make their case. The patient can then ask questions to the treating team. The lawyer will usually ask a bunch of questions. We'll get grilled, which is good, right? We need to be grilled. It needs to be a kind of, it's not personal. It's not saying we're bad doctors, but it's about making sure we're doing the right thing in terms of society's values and the safety of the person, others, and society. So look, that's the PTO. I guess the other thing in the PTO report that needs to be mentioned is capacity. So the assessment of like to give someone involuntary care, you're saying they do not have capacity. What is capacity? It's the ability to understand an issue, a problem, to understand all the different solutions to that problem, the consequences of those solutions, to weigh up the pros and cons, and to arrive at a reasonable decision. It is decision specific. So someone with severe brain injury might have capacity to say whether they need to go to the bathroom or not. They might be able to say if they're hungry or not. They might have capacity for those kinds of questions, but if you're asking them, do they have capacity to decide whether they need antidepressant or an antipsychotic for their treatment, or whether they need an antipsychotic for their behavior, they might not have capacity to answer that question, because they don't understand the risks that they might put other people in if they were an aggressive person, for example, because of this brain injury. So I don't know, I kind of went on a tangent there, but the point is capacity is decision specific. In the Mental Health Act, it's do they have capacity to decide on their mental health treatment? If someone's psychotic, doesn't have insight into the psychotic illness, doesn't want medicines, has a history of being at risk of hurting others or themselves, then unfortunately they don't have capacity for that decision. I always try and increase autonomy and let them choose what medicine they want. Try and find the best dose for them, work with them as much as possible. But at the end of the day, we can't. There's a certain level of risk we can't really accept. And I acknowledge that risk assessments are flawed, and we can talk about that in another video. But that's the way that things are at the moment. All right, look, so it's 35 minutes of filming. I'll try and edit it down, and I don't think I'll talk about ECT in this video, or advanced kind of care directives. But if you guys want to learn about it, leave a comment down below and I'll make a video about it. And leave any comments about any questions you've got. If you have any differences in the Mental Health Act in your states, because you're not in Canberra or whatever, put those in the question, put them down in the comments below. I'm just going to keep making videos about things I feel like making videos about that I find useful for me and other people. And I wish you all a beautiful day. But yeah, if you want a video about a particular topic, the best way to let me know that is by leaving a comment, and I'll do my best. Oh, that's a big video. I'll see you all in the next one. Bye for now, guys.